Hi, everyone. My name is Elizabeth Volkmann, and I'm a rheumatologist at the University of California, Los Angeles. I'm really honored to be here today to share this journey with you, and I'm excited that some of you are there in person as well as logging in online. And I just want to thank the NSF for inviting me to speak with you today on a topic that I feel that often doesn't get addressed adequately in the clinic, and that is the pregnancy journey in systemic sclerosis or scleroderma. So the objectives of the talk today, we're not only going to talk about the pregnancy journey in systemic sclerosis, but we'll also review fertility as it relates to both women and men with this condition. And then we'll review preconception planning as well as discuss assisted reproductive technology. And how I approach caring for patients with systemic sclerosis is really to empower patients with knowledge so that they can make their own informed decisions and we can work together as a partnership. So I think as you're taking in this knowledge and information, just keep in mind that these are general sort of information points, but really you're a very unique person and patient. So you'll want to talk with your doctor to find out what is the best approach for you. So let's jump right in. So first, I just wanted to go through a few definitions that I think will help us as we go through this talk today. And the first is the medical definition of infertility. And this is the failure to establish clinical pregnancy after 12 months of regular and unprotected intercourse. You may also hear the term assisted reproductive technology. It's sometimes abbreviated as ART or ART. And this is any fertility-related treatment in which eggs or embryos are manipulated. And then I'm sure many of you have heard the term IVF. This stands for in vitro fertilization, and we'll talk more about what this means later in the talk. So just to start, fertility in women with systemic sclerosis, there's been studies on this topic, and the studies have demonstrated that the rates of infertility in women with systemic sclerosis are similar to the general population. Also, the rates of successful pregnancies in patients with and without systemic sclerosis are also similar. But despite these statistics, many women with systemic sclerosis are counseled to avoid pregnancy. And there may be really various different reasons for why women are counseled in this way. So one is that this is a rare disease with many unknowns. So it may be difficult when you're first diagnosed to predict which organs are going to be affected. There's also a concern that many women and sometimes healthcare providers have that a woman with scleroderma may be too burdened by the disease in order to care for a child. And there's just this general lack of understanding about how scleroderma affects both the woman and the fetus. And as many of you know, when there's many unknowns, this can make doctors feel uncomfortable. And when doctors don't have all the knowledge that they need to talk to patients about topics, sometimes they avoid bringing them up. So I see this as an issue that not only relates to the patients, but also the healthcare providers. But we have a lot more information now about fertility in patients with scleroderma, and these come from some nice studies that were led by Virginia Steen at University of Pittsburgh and other centers throughout the world. And the rate of infertility in women with scleroderma is 15%. The rate of successful pregnancy in patients evaluated for infertility is 37%. And this compares to rheumatoid arthritis, where it's 40%, as well as patients without an autoimmune disease, where it's 43%. So it's fairly similar for these other populations. As well, the rate of early miscarriage, which is defined as having a miscarriage at less than 10 weeks gestation, is also comparable to the general population. And there's different, reasons why someone may decide to delay conception in their life. And this could be related to having a new diagnosis or having very active disease that requires treatment. There can also be challenges with just the physical active intercourse, and this affects many patients who have diffuse skin disease. There's often a fear that patients have and their family members about how pregnancy will affect their body. And there's a worry about stopping medications, and specifically medications that we know are not safe to take during pregnancy, but that we use to treat scleroderma. So really, because of all these factors, it's very important to plan ahead. So preconception planning is essential. And what's important for you to take away, I think, not just from this talk, but from all the talks that you'll hear this weekend, is that knowledge is power. The more information you have about your own disease and the more awareness you have about your own desires and goals in life, the better you'll be able to make this important life decision. So what changes could you expect to happen if you were to get pregnant and you have scleroderma? So the first thing is that we do have statistics from studies. So there was a study done, again, at the University of Pittsburgh, where they looked at what happened to the scleroderma while the patients were pregnant. And so in 60% of patients, they reported stable disease. 20% actually had improved disease, and 20% had worsened disease. But remember, these statistics apply to a group, and you are an individual. So you don't know which one of these categories you may fall into. And it could be that parts of the pregnancy you feel better and other parts you may feel worse. Some of this may relate to scleroderma, some of it may not. What can improve though during pregnancy? And generally we see that Raynaud phenomenon improves during pregnancy. So this is when you have these color changes and cold sensation, typically in your extremities, like your hands and feet. And what happens in pregnancy is that the blood vessels dilate or get bigger and they open more. So you actually might perceive improved circulation and less digital ulcers. And this picture here just sort of demonstrates what I mean by dilation. So on the left side here, you see a normal artery. And then when you have constriction, which is what happens in something like Raynaud's, the blood vessels narrow, so less blood can flow through. And then when you have vasodilation, which is on the right here, this is when the blood vessels dilate or open more and you have better blood flow. So pregnancy is a state where naturally, even people without scleroderma will have this vasodilation or this opening of the blood vessels. And so patients with scleroderma will often report that their Raynaud's gets better during pregnancy. What about things that can get worse? So one of the things, and this may seem obvious to those of you who've been pregnant before, is that reflux disease can get worse. And this is because, as you go further in your pregnancy, it increases your abdominal pressure and this pushes up on the stomach, and this can worsen reflux symptoms. Obviously, nausea and vomiting can occur in the first trimester, and sometimes this could be worse if you're already dealing with nausea and vomiting as part of your scleroderma symptoms. And there is evidence that small intestinal bacterial overgrowth, or SIBO, can sometimes worsen, and this could potentially affect the health of the fetus, but there's more research that needs to be done in this area. So this figure is just meant to help demonstrate how that increased abdominal pressure from the growing baby inside of you pushes up on the stomach and then can cause the stomach contents, including the acid fluid, to go up. And in this part here, this is esophageal sphincter. This is the part in scleroderma that even in patients who aren't pregnant tends to become relaxed and allow reflux to happen. So you can imagine that when you have pregnancy, the reflux could get a little bit worse. And why is this important to know? Well, there's ways to be proactive about managing these symptoms, and you may want to stay in close contact with not only your rheumatologist, but your gastroenterologist to help manage these symptoms and be prepared for what can happen. What about other things? So pulmonary hypertension is something that we tend to worry about in pregnancy. So because your blood volume increases during pregnancy because of that process that I told you about, the vasodilation or the opening of the blood vessels, this can create an extra demand on the heart. The heart essentially has to work harder to pump the blood during pregnancy, and there is a risk of death. And so in one study of patients with pulmonary arterial hypertension due to different causes, not just scleroderma, the mortality rate was 33% during pregnancy. So that's 1/3 of patients. That's quite high. And the mortality risk was highest during labor and 1 month postpartum. So generally, patients who have pulmonary hypertension are advised not to get pregnant, but there are other options to have children for these patients, which we'll talk about later in the talk. But sometimes, what happens is that patients who have pulmonary hypertension happened to get pregnant and maybe they weren't even planning it. And so we do have experience treating these patients. And when we really work together as a multidisciplinary team, we can actually often achieve good outcomes even for these patients. And so this was a nice paper that I recently read, which kind of described the experience of one very good medical center that cares for a lot of patients with pulmonary hypertension and how they approach treating patients who are pregnant. So obviously, the first step here is to diagnose the disease, and I'm sure there's going to be a talk today on pulmonary hypertension, so I won't go through this in too much detail, but typically we diagnose this by doing an ultrasound of the heart. We get a right heart catheterization, and we also measure blood biomarkers, and then sort of assess the risk. How serious is this pulmonary arterial hypertension? Form a multidisciplinary team that not only involves your obstetrician, but also your pulmonologist, maybe your cardiologist too. And then try medical therapy. And obviously, your medical therapy needs to be something that's safe for both you and the fetus. And generally, because the delivery and postpartum period is the period of time where the mortality risk is the highest, this is the time where patients really need to undergo very close monitoring. And in this paper, they advise some specific guidelines that can be helpful. So again, we typically counsel patients who have pulmonary hypertension to avoid pregnancy, but if it happens, there are ways to manage this. What about new symptoms that could sometimes come up? So one new symptom that can arise during pregnancy is changes in your blood pressure, and specifically an increase in your blood pressure. And this could be a sign of kidney disease. And oftentimes we don't know exactly what kidney disease it is until we get further information. So it could be a sign of renal crisis, which is organ involvement from scleroderma. It could be related to preeclampsia, which is a condition that's not related to scleroderma and can happen in patients who don't have autoimmune disease. And sometimes patients can have a second autoimmune disease that shows up during pregnancy, like lupus nephritis. And so your doctor and your team of doctors will work together and do various tests to be able to understand what is the exact cause of the kidney disease and the increase in your blood pressure. Renal crisis has an incident rate about 2% in patients who are pregnant with scleroderma, and it's most likely to happen between 16 and 28 weeks gestation. And the symptoms, can be kind of vague. So headache, nausea, fatigue, feet and leg swelling, shortness of breath, these can all occur normally in pregnancy. So really, it can be sometimes very difficult early on to distinguish what could be renal crisis versus what could be just normal symptoms that happen with pregnancy. But other more specific symptoms could include confusion, visual disturbances, seizures, as well as dizziness. And this is a pretty serious complication when it does happen during pregnancy. What about skin fibrosis? Because this is a question that I hear a lot from patients, and studies suggest that it does not worsen during the pregnancy, but it can flare afterwards. So in one study, postpartum, up to 15% of patients with both diffuse and limited skin disease experienced worsening with a mean skin score increase of about 7 points. So for those of you that are familiar with skin scoring, you know that we measure skin thickness in 17 different parts of your body, and we add up the scores. So it goes from 0 to 51, 51 being pretty severe skin disease. And so an increase in 7 would be considered a pretty clinically meaningful increase in skin disease. And some of this may happen because the medications that we need to use to treat skin disease, many of them we have to stop during pregnancy. And also the postpartum period tends to be a stressful time as you're adjusting to having a new baby, and you may not be sleeping as well or eating as well. And all of this could contribute to the increased risk of flare. But again, having this knowledge can help you prepare to maybe do more things and get more help to make sure that you don't have extra stress during this postpartum period. And other symptoms, so shortness of breath is something that can happen just naturally in patients who are pregnant, even those without scleroderma. In fact, about a third of patients who are pregnant report feeling the sensation of breathlessness. Again, some of this may be due to that increased abdominal pressure, kind of pushing on your diaphragm, particularly when you lie down. But if you do have a lung disease like interstitial lung disease worsening shortness of breath could be related to that. And there are some reports of patients who have mild ILD who get pregnant and they have successful outcomes. So just to summarize some of the symptoms and what to expect, and again, these are sort of just general things that can happen, but you as an individual, it might be different for you. But by and large, Raynaud's typically improves during pregnancy. A lot of the GI symptoms can get worse, like reflux, nausea, vomiting. The skin usually stays the same during pregnancy, but can worsen afterwards. And then you'll want to have extreme caution if you have a history of pulmonary hypertension or even renal crisis, and really work with your doctor in your preconception planning if you have these conditions. So what does that planning really entail? And I think, your physician might not bring up this topic with you. And I find that most physicians who even specialize in the care of patients with scleroderma don't raise this issue. And there's likely different reasons for this, right? When you have scleroderma, you may have a lot of different symptoms and experiences going on in your body, and these things take precedent over other things like planning for having a family. And so you may need to be the one to initiate this dialogue first. And I would consider scheduling an appointment specifically with your doctor to address this topic. Because again, what happens sometimes is this topic kind of gets pushed to the end of the visit and then doesn't get the attention that it needs. So if you really want to have a thoughtful dialogue with your physician about preconception planning, I recommend writing them a message ahead of time, either in whatever email my chart that you use to communicate with them or call in the office. Part of the reason I recommend this is that your physician might not feel comfortable talking about this. And it's always better to know that ahead of time. And they may say, oh, but actually this doctor could talk to you about it. So again, I would try to plan ahead for this type of discussion and to allow it to be highest yield for you. And I believe in shared decision making. So on this left side here is sort of the old model of medicine where it was very unidirectional, right? Where your physician would basically tell you about the research and then give you instructions. And then you were told to follow these instructions. But now we practice this more, or at least I do, bi-directional, patient-centered view, where really we're just educating patients, empowering them, making it like a partnership so that the decisions are shared. And I think this approach is particularly relevant for this topic because it can be a very sensitive topic to discuss. And I think we have to have this open, shared communication. So when you're thinking about having this discussion with your healthcare provider, make sure that they're following this kind of patient-centered view and not just telling you what to do or not to do. And the preconception planning really needs to be tailored to you. If you just have a provider that reads you these statistics and that's the end of it and then leaves it up to you to decide, that's not really what you want to gain out of preconception planning. You want to review what are your unique symptoms of systemic sclerosis and how are they likely to change if you get pregnant? What are your medications? Which ones are safe to continue taking? Which ones are not? And planning ahead for that, because maybe there's an alternative medicine that you can start now before you get pregnant to make sure you tolerate it and to make sure it works effectively for you. What are your life circumstances, your support network? All of these things can be factors in your preconception planning. And then patients with scleroderma sometimes have other medical issues too that can affect the pregnancy state. So you want to make sure that your healthcare provider is looking at you as a whole person and not just this one specific disease. And I would recommend visiting a scleroderma center. And obviously I'm somewhat biased because I practice at a very good one. But I think that the scleroderma center, what's nice about them is they often have multiple specialists, not just rheumatologists, that are quite adept at caring for patients with systemic sclerosis and have cared for patients who are pregnant. And you want to have a completely thorough history and physical and really assess how is the scleroderma affecting your body. So even if you're only able to come one time, this would be beneficial. And a lot of centers, myself included, will do video visits and telehealth, and you can send your records ahead of time for us to review. But you want to have a complete history and physical. You want to have had a CT scan of your chest to see if you have pulmonary fibrosis. You want to have those breathing tests, which I know are a pain to do, but really help us understand the severity of the lung disease you have. an echocardiogram or an ultrasound of the heart, and then lab tests, because we look for specific autoantibodies that can sometimes give us insight into how the scleroderma is going to evolve and what organs will be affected. So seeing a doctor who cares for pregnant patients with scleroderma on a regular basis, I think, is very important if you're going to embark on this journey. And you want to create a multidisciplinary team, and your doctors should sort of just naturally create this for you. But I would have an awareness about who the key players are. So you obviously will have your rheumatologist. You'll be seeing a high-risk obstetrician. And what this means is that it's an obstetrician that is used to taking care of patients who have chronic diseases, including autoimmune diseases like scleroderma. You may have a pulmonologist and cardiologist, particularly if your lungs are affected. If you have a lot of GI symptoms or your GI symptoms get worse during pregnancy, you'll want to have a gastroenterologist on your team. And then again, if you have kidney involvement, you'll need a nephrologist. And all of these different doctors should be talking to each other and really working together as a team to make a plan for you. What about postponing pregnancy? And again, sometimes there's not an option to postpone depending on your age, but most of the time you can. And I would think about your disease stage when you're making this decision of whether or not you want to start having a baby. So if you were diagnosed, for example, with diffuse skin disease less than 5 years ago, you may want to postpone. Patients with diffuse skin disease, typically within that first 5 years, that's when a lot is happening. That's when the skin often gets worse. That's when organs often become involved. And that can be a time where the disease is very active. You know, it's a little bit different when patients have limited skin disease, because typically patients with limited skin disease, they can still get organ involvement, but it usually happens at a slower pace. So this 5-year mark that you often hear about, it really just applies to patients with diffuse skin disease. You might want to also postpone if you were just diagnosed regardless of skin disease, you know, coping with a new diagnosis, getting information, formulating your team of doctors. This can take a lot of time and effort, and it may not be the right time to get pregnant. And then your medications matter too. So you may have to, you know, come off of a medication, and maybe it's not the safest time to come off of it. So if there are medications that you're on that pose a risk to you or the fetus, you will definitely want to postpone until you've safely come off of them. And this should be done under the supervision of your physician, because again, some medications cannot be stopped abruptly. They could cause more harm to your body if you do that. So I wanted to go through a couple of cases just to kind of give examples that would maybe help you understand how this process happens for patients. And, you know, there are situations where patients who are pregnant develop scleroderma while they're pregnant. And so this can be a very tricky situation. So I cared once for a 36-year-old woman who was pregnant with her second child. And 3 months into the pregnancy, she developed reflux disease, but didn't think much of it because reflux, as we know, can happen during pregnancy. 4 months into the pregnancy, she noticed her hands started to feel puffy. But again, a lot of pregnant women retain water, and she just thought it was because of that. But then 6 months into the pregnancy, she felt her skin start to harden, and she knew something wasn't right. So she eventually saw a rheumatologist, and at 7 months was diagnosed with diffuse systemic sclerosis. So you can imagine how challenging that would be for someone who is 2 months away from delivering, has one child already at home, and now has this pretty serious diagnosis. And so she came to see me. And again, the important thing is that you do a thorough evaluation. And we can do all these things during pregnancy except for the CT scan, because we want to avoid radiation. But we can do our history and physical, look at the extent of skin disease, pulmonary function test to get an idea of does the patient have lung disease and how severe is it. We can do an echocardiogram, which is just an ultrasound of the heart, and pregnant women are already getting ultrasounds of their abdomen. And then we'll do those blood tests too to look at the antibody profiles to help us understand what the patient's risk is for other organ involvement, like kidney involvement or lung involvement. And I think it's pretty essential that if you're pregnant and you get a new diagnosis of scleroderma, that you really see a scleroderma specialist to help guide you through this journey, because this is going to be a little bit challenging because some medications and interventions and tests will have to be delayed until after you deliver. And so in this case, she had diffuse skin disease. Her antibody profile was positive for SCL70. And this is an antibody that we often see in patients who have diffuse skin disease. And we also see it in patients who have lung disease. And based on my exam, I did hear some crackles in her lungs, and she did have pulmonary function tests which indicated restrictive physiology that she likely had interstitial lung disease. So we decided, she had 2 months left of the pregnancy. We just wanted to closely monitor her. She did not want to try any medications. And we had planned to start medication 6 months after delivery because she wanted to breastfeed. But then we stopped at about 3 months because her skin disease started to worsen and her lung disease started to worsen. And so I mentioned this because while you're pregnant and you're making plans about when to start medications, during this time, you still want to be monitored very closely by your doctor. If I had just said, okay, come back in 6 months after you deliver, her skin would have already been even worse than it was at 3 months. So really, you should be followed very closely. And this patient did a wonderful job of following up with me every month after she delivered. And we really work closely, and she's doing quite well now and has 2 healthy boys. What are your other options though? Because for many patients, pregnancy is not something that they want to consider. And there are other options. And fortunately, we have what's called now assisted reproductive technology. And this is an option for patients with scleroderma and people who don't have scleroderma who are struggling to conceive naturally or don't want to. It's also an option for patients who want to use a surrogate to carry their baby. And this is one of the most rapidly evolving fields of medicine. And I would say that one of the most important points here is that usually your reproductive endocrinologist is not a normal part of your care team when you have scleroderma. So you want to make sure that that doctor has good communication with your rheumatologist and any other key stakeholders in your care team, like pulmonologists. And living in Los Angeles, there's a lot of reproductive endocrinologists. And I've gone on this journey with many of my patients, and I'm pretty choosy about which ones I'll work with because I want them to communicate with me. And so for you as a patient, a way to test this is if you go for an evaluation from one of these REIs or reproductive endocrinologists, you need to say, I want you to work with my rheumatologist. Here is their name, here is their email, here's their number, please contact them. And see if they follow up on that, or see if the rheumatologist tries to reach out, they can't get through. You really want someone who's willing to work as part of a team. And I think this is quite essential if you decide to go down this route. And there's different options available, and I'm just going to go through a broad overview of options. But when you first meet with a reproductive endocrinologist, they're going to perform different tests, like a pelvic ultrasound to look at your ovaries. They're going to do blood tests to check your hormones. And then based on those tests, and as well as life factors, they'll be able to work with you to come up with a plan that's specific for you. So they'll be able to tell you, statistically, what are your chances with intrauterine insemination or IVF. But what this means, intrauterine insemination, it's sometimes abbreviated as IUI, is just injecting sperm into the uterus of a patient. IVF is when you use an egg and sperm to make an embryo in the laboratory, and then that's implanted either into you, the patient, or into a surrogate. And again, your REI doctor will go through each of these options in detail with you to figure out what is the best option for you. And again, this is an example of the intrauterine insemination. It's a pretty easy procedure. It's done around the time that you would naturally ovulate, and the sperm, can either be fresh sperm or it could be sperm that's been frozen and thawed, and then it's just injected into your uterus. So it's not a painful procedure, and it takes a few minutes actually. IVF is a little bit more of a complicated process, and this is because you're given medications, hormones mostly, to help stimulate your ovaries to produce a lot of eggs. So normally when you naturally menstruate and go through your menstrual cycle, you'll have one dominant follicle that will release an egg. But in IVF, they want you to release a bunch of eggs so that they can harvest them all to help make embryos for you. And so you'll get medications that will stimulate the ovaries, and this process often produces, bloating, some kind of abdominal discomfort. And then what they'll do is once you're at the point where you're just ready to ovulate, they will go in and harvest the eggs. And this is a procedure that's done under anesthesia. There's really no pain involved. The infection risk is very low. And they'll use a catheter, again, to extract those eggs. And then you really have two options. One would be to freeze those eggs for a later time. Another option would be to create an embryo. And this, again, is where either the fresh or frozen and thawed sperm is then put in a dish with the egg to see if an embryo grows. And the way this process has been described to me, I think as like kind of a reverse pyramid. So you may start out with like this many eggs, and then, this many grow into embryos, and then a few embryos are the ones that are the best quality. And they assess quality, using different metrics. And there's even a possibility to do genetic testing on embryos to make sure all the chromosomes are intact. And so again, once the embryos grow, you can freeze them for later use. But eventually, if you decide to have them implanted, then they are surgically put into the uterus. And again, that's a pretty simple process too. So I would say this is an option, again, that some patients decide to pursue, especially some patients who decide that I want to have a child, I want to create an embryo with genetically my DNA, but I'd rather use a surrogate. And so that's a possibility as well. And so here's an example of a patient I cared for who decided to go that route. So it was a 35-year-old woman with diffuse systemic sclerosis, and it was diagnosed 7 years ago. And she had been taking mycophenolate for the past 5 years. And her skin disease improved immensely on the mycophenolate, but she was really worried that if she got pregnant, her skin disease would worsen again. So she decided to do IVF with surrogacy. So basically, we came up with a plan. We decided to stop her mycophenolate 2 weeks before she did the stimulation cycle. And what this means is 2 weeks before the doctor started giving her all these hormones to start stimulating the ovaries to produce a lot of follicles. And then we decided to resume the mycophenolate 2 weeks after they did the egg retrieval. And I wanted to give her 2 weeks time because there is, a slight risk of infection with the retrieval. It's not very high. But, I wanted to give her time too to detox from all the hormones that she had been taking. And so she was off the mycophenolate only for 4 weeks. And during this time, she did not have a flare-up of her skin disease. And then her surrogate delivered a healthy girl, and she's very happy now. So this is also an option. You can go through the IVF process and use a surrogate if you don't want to try to get pregnant. I want to make sure I talk about men with scleroderma. This has been a talk that's very heavily focused on women for obvious reasons. But it's important to know that fertility in men is an issue. And unfortunately, we have few studies that have evaluated this, but erectile dysfunction is common in men with scleroderma, and it can affect intercourse. Another important point is that some medications that we prescribe can decrease fertility in men. And the effects are typically reversible, but with rare exceptions. I'm going to go through those with you. So one small study, and it only had 30 patients, so we have to take it with a grain of salt, found that low testosterone was observed in about 23% of men with scleroderma. And the risk factors for low testosterone in this study were high triglyceride levels, so this is like a cholesterol metric, and older age at the onset of scleroderma. And so both of these, triglycerides, high triglycerides, older age, are already associated with having low testosterone. So it may not even be related to the scleroderma, but some of these other factors. In terms of medications, the one that you should be aware of that can cause irreversible infertility is cyclophosphamide. And this applies to both women and men. I use this medication very rarely now because of its toxicity, but it can cause oligospermia or low or no sperm count. But there are fertility preservation options available for men. So for example, if your doctor tells you you're going to start on cyclophosphamide, you have the option to cryopreserve your semen, meaning freeze your semen to be thawed and used at another time point. There's also some evidence that co-administering testosterone, so taking the testosterone at the same time as you're receiving the cyclophosphamide, can help reduce the chances of you developing low testosterone during your treatment. So I'm going to summarize now, and we're leaving plenty of time for questions because I thought this might generate some questions. But basically, what I want you to take away from this talk is that the rates of infertility between women with systemic sclerosis and the general population are very similar. During pregnancy, some symptoms of scleroderma can get worse, like the GI symptoms, the shortness of breath. Some can get better, like the Raynaud phenomenon. And then other things you really want to have a thoughtful dialogue about with your doctor. If you have pulmonary hypertension or kidney involvement, these are issues that you really have to work with a multidisciplinary team if you're going to consider pregnancy. And because new complications can arise, having that multidisciplinary team in place right at the beginning can be very helpful. So you're not, scrambling to research who's the best pulmonologist, who's the best cardiologist or nephrologist. You've already met with them, established care, and kind of formulated this team. And then assisted reproductive technology is an option for patients. And this could be things like the IUI, IVF, this could be implanting an embryo into you or implanting it into a surrogate. So there's a lot of options. And I, again, encourage you to speak with your doctor before you decide to conceive, to talk about what your options are, to speak about how the scleroderma is affecting your body and what could possibly happen during pregnancy. Because again, I think this is a really important topic that does not always get discussed in the clinic. But as someone who deeply cares about patients with scleroderma, one of my intentions in caring for patients is to help them achieve all of their life goals despite having scleroderma. So if family planning is something important to you, please bring this up with your physician. And I want to thank you for your time today. Some of you may know that I send patients with scleroderma and other autoimmune diseases a monthly email with kind of tips about nutrition and general self-care as it relates to having an autoimmune disease. And if you're interested in signing up for this, you can email my assistant, Nancy, at nancyrlopez@mednet.ucla.edu. And I'm happy to entertain questions now. And I just, again, want to thank you for all of your time today. All right. So I'm going to pull up the questions here. So the first question that came up, and I think for those of you that are there live in the audience, unfortunately, I cannot see you. So the best way to ask a question is through the app. And so the first question is, I have cardiac involvement and recently diagnosed with heart failure and had an ICD placed. Due to this, would it be best to use an alternative method for pregnancy? I think it would be good in this situation to consider an alternative method, but your cardiologist and your rheumatologist and obstetrician would be in the best position to make this decision because they would have access to all your records to know how severe your heart failure is. But as I mentioned before, during pregnancy, the heart has to work harder as it is. So if your heart function is already compromised, they may say it's not safe for you to do this. But I hope from this talk today, you've learned that there's other options to pursue, things like IVF and surrogacy that could still allow you to have a baby. So that's a great question. Another question that was asked, and this is, again, another great topic that relates to family planning is, do we know if scleroderma is genetic, or is there a risk of passing this disease to your biological child? And this is a really great question. We think with autoimmune diseases, there is some genetic susceptibility to getting it, but a lot of factors in the environment probably matter more than just the genetics. And we know this because there's been studies looking at identical twins, so two people that share the exact same DNA. And if one patient has scleroderma, the other identical twin only has about a 5% chance of getting scleroderma. So that whole 95% is likely because environmental factors mattered more. So I very rarely see, I think I follow one patient now whose mother had scleroderma, but it was an entirely different type of scleroderma than what she has. It's quite rare to see this running in families. What we see more is that patients with scleroderma will describe, I have an aunt with lupus and a cousin with rheumatoid arthritis. So again, demonstrating that there may be some genetic risk to autoimmune disease, but there's a lot of environmental factors that need to happen in order to cause this disease to manifest. So I would say, no, you're unlikely to pass scleroderma down to your child if you decide to have a baby. Good question. Oh, great. So has research been done specifically on morphia in pregnancy? And I'm not aware of research specifically on morphia, but what I would say is that with this condition, morphia can sometimes be treated with the same medications that we use with systemic sclerosis, particularly if the localized morphia can become more extensive and affect greater regions of the body. And in these cases, you might have to work closely with your rheumatologist to taper off of medications or try alternative medications that are safe to take during pregnancy. So I think more research is definitely needed there, and it's a great question. All right. We definitely have time for more questions. We have about 15 minutes left. And again, I can't see you in the audience. I wish I could, and I wish I could be there today. But if you have questions, please feel free to write in the chat. Okay, perfect. So one question was, what environmental factors matter the most? And I wish we knew all of the answers to this, but I can speak a little bit to this issue because there are some environmental factors that have been found in some kind of epidemiological studies to maybe be important. And so these are exposures to certain chemicals like solvents. Exposure to silica dust has been linked to scleroderma. But there's many factors that we don't know. And I would say a big factor that I see in my patient population as maybe contributing in some way is stress. So oftentimes before a patient is diagnosed with scleroderma, they go through some kind of tremendous life stressor. It's a loss, a divorce, something very significant happens in their life, a car accident, and it can trigger this kind of cascade of events. And so obviously, the human experience, we're meant to undergo stress. It's a normal part of life, but it's these pretty significant life stressors that people undergo that I feel like can contribute to patients developing autoimmune disease. In a slightly unrelated topic, but something again that I think is important for patients is that I also see this pattern of behavior in many of my patients, not just with scleroderma, but with autoimmune disease in general, where there's this tendency to really care for other people and sometimes care so much for other people that it comes at the expense of caring for yourself. And so sometimes these autoimmune diseases kind of pop up as sort of signals that we need to do a better job of putting ourselves first. And this is not easy. It does not come naturally to me. And so it's something, I've had to learn over time and I'm still working on. But this is something that I don't know if I'd call it environmental. Maybe it's more behavioral, but it's something that if you're on a journey with scleroderma, something to just pay attention to. Like, do you think of yourself? Are you giving yourself enough love and self-care? Because again, I see this pattern in a lot of patients with scleroderma, and it's a sign that you're a good human being when you care about other people, but it shouldn't come at the expense of caring for yourself. Other questions? This is a quiet group. All right. Well, I will be available in the chat. Oh, wait, there's been one more. Do you provide virtual consultations to those in Florida? So yes, I can provide virtual consultations. It's always more ideal to come in person, especially for the physical exam, but we can do virtual consultations for patients out of state, particularly because this is a rare disease. The university where I practice has made exceptions for me and other providers who care for patients with rare diseases where they know there might not be a specialist in the area in which they live. So this email here is one way to connect with me to schedule an appointment. And I think also on my profile in this app, there's also a link to the website for where I work at UCLA and the phone number to call to schedule an appointment. But we can definitely do virtual visits, either video or telephone too. Yeah. And then we have a couple more. Yeah. So yeah, I look forward to connecting with anyone that's interested in talking about this topic. The other issues that I often speak about are lung disease and scleroderma, as well as the GI tract and the gut microbiome and nutrition. So again, this newsletter will address some of these topics that I think, again, don't often get addressed during the doctor's visit because there's so many other topics to address. But things like modifying your diet can also be really helpful when you have this condition and help control some of your symptoms. So that's something that I like to work together with on patients too. All right. Well, thank you so much for your time and attention today. And I really wish you a wonderful time at this meeting. This is just such a great opportunity for you to learn from all these different experts in the field, to connect with other patients and other caregivers. And again, I'm so grateful to the National Scleroderma Foundation for putting forward this event and inviting me to be a part of it. So thank you so much for your time today, and take care.